we're here at SIR, everyone is talking about the new training paradigm. We've now graduated our, 2 full classes all the way through of the integrated IR program. The training paradigm is changing. We live in a time where people are going more towards teleradiology in the diagnostic field, and IRs are still considered a commodity under radiology.
Yeah.
Yes? So how does this affect locums? How does the new training, it's a very broad question, so take it however you will. How does the new training paradigm shift and the society's shift in a clinical IR, it's going to be a long shift, how does that affect locums? Staffing, filling spots, all of this.
So, I can start from the OBL side.
Yeah.
And I actually think when it comes to OBL locums, I think it makes these opportunities harder to come by. And I don't think that's necessarily a bad thing because I think we're actually starting to see more young IRs coming out who want to be in OBLs, right? They want to be in OBL ASC practices, whether that's physician owned and operated, corporate, MSO, whatever, multidisciplinary, you name it.
Outpatient
medicine. And, I feel like that is where we're going to be headed, right? I'm not saying that's like the end all be all answer to all of our problems. You still need a hospital to do good work. Certain types of patients have to be treated. But I think when it comes to OBL opportunities, I think, we're going to be seeing more full-time employment in these settings. I think we're already starting to see it. So when it comes to staffing needs in the OBL, the biggest issue right now is, can you have an owner or operator or a primary physician in any one of these facilities who's willing to take on a novice partner to do this? That's the problem. It takes at least a few years to get up to speed on what's necessary to be safe and efficient in the OBL setting. And, there's always going to be opportunities to kind of fill staffing needs from that perspective. But I think over time, it's probably going to dwindle. That's kind of my crystal ball, which is admittedly always a little cloudy. But I think when I think of OBL, I think about it from that perspective. I'd be curious, Vishal, what you think about the hospital.
Well, I just want to interrupt real quick. I mean, it's a good point, and you have your finger on the pulse. I mean, I doubt there are many people here at SIR who have as many contacts in both the inpatient and outpatient world as you do. I have a ton in the inpatient world, but I have very few in the OBL world. So I think your perspective is going to be very well taken.
And I want to touch base on the OBL stuff you're talking about, because I think I may mention this in the first episode. That was my intention out of training, was to open one in Atlanta, and didn't end up working for a variety of reasons I described in the first podcast. But I think you could make the argument that the OBL ASC topic in interventional radiology is a recent one, and it's a developing topic that represents a change that the field wants to make. They want to move into the outpatient sphere, own their patients, et cetera, et cetera. And so, and then of course you're seeing private equity take over a lot of radiology. You're also seeing a lot of teleradiology. So I view locums, and it's, I don't know the numbers off the top of my head, but just anecdotally, I feel like there's a lot more interest in locums radiology, interventional or diagnostic combined, is just a representation of the shifting in the field and people trying to figure out what they want. Now, whether locums radiology or interventional radiology in this case is a permanent thing, would, I think, very much differ from the OBL space versus the ASC space. I mean, the inpatient hospital space. But like, I'm excited, for example, we're talking about new trainees. I'm excited for someone to say, maybe someone listening to this podcast right now, maybe someone who's a resident right now at a IR program saying, hey, Kavi's going down to Florida to do a bunch of PAE. We don't do a whole lot of this here. Why don't you take me out there and let him, you could be developing an academic, I'm giving you some ideas, and maybe you've already thought of them. You could develop an academic affiliation. And this is, I think, one of the major pitfalls of our own field. And I'm not the first to say this, I know it. Right. We talked about this last night. I've talked to a lot of people ad nauseum. Not all programs offer everything, but there are plenty of people out there who are doing high volume stuff. Why are we not sending?
And willing to teach.
Absolutely. I know some older people that are getting ready to retire who are going to take 3 decades worth of experience to the grave, and have they taught a soul? They haven't had the opportunity to. Yeah.
So I was just speaking outside the convention center with Kavi with a pretty prominent member in the early career section.
Yeah.
We were speaking about how there's this new initiative amongst the early career section to have trainees come out to OBLs and learn techniques.
Yeah.
I quickly mentioned that actually Kavi, a friend of ours, Ely Baelish, and I actually posited this on the IR Facebook group with about 2 to 300 radiologists are on that group.
Yeah.
We actually said, please anonymously leave your email if you are willing to host medical students, residents who are not getting peripheral arterial disease exposure, and you are doing it. Initially, when it was anonymous, we had tons of people saying, bump, follow me, all this stuff. As soon as we actually linked the spreadsheet, I think we got maybe 2 people who listed their email. We had tons of people interested from the resident side, but we had very few people who wanted to see it through and do it from the teaching standpoint when they had to put their name down and commit to it. It's a small sample size, and it's just off Facebook. It was not done through the society. So this is purely anecdotal, and it was more of a thought experiment than it was a formal opportunity. But I think this idea is real, and I think that there are plenty of people out there who are willing to offer
I can't
it.
speak about the OBL space, but I can tell you that I've hosted a medical student for training, which is something that sort of landed in my plate, and I found it extremely gratifying. And it made me actually go back to some primary literature before I taught any black pearls. So that's shocking to hear, and maybe saddening if true. Maybe not true, which would be hopeful.
I'm hopeful that because it was on Facebook.
Yeah, exactly.
In an IR group on
I think
Facebook.
it probably wasn't the right audience, because I think it's still going to be mostly hospital based to begin with, and I think maybe if we were to even in SIR, it's still predominantly hospital based. I think if we were to raise a similar suggestion to something like OEIS, we'd probably get more people. Yeah.
I wonder, to take it a step further, I wonder what you guys would think if we were to raise this idea to multi-specialty collaboration for trainees to go out to vascular surgery ASCs, to interventional nephrology ASCs, to interventional cardiology OBLs, and to see if we could get some of that restitution for decades of innovating and collaborating.
That's a bold
over
suggestion.
the last 40 years. I mean, as a society, the question is, as a society, is that something that we are willing to at least promote? We don't have to pound on doors, but is that something that we would be open to suggestion to? And that's all I'm asking.
I'll give my thoughts on that. So, I'm married to a vascular surgeon, and I was actually a business partner with an interventional cardiologist. And I actually learned most of what I know about PAD, not from an interventional radiologist, but I was actually taught by an interventional cardiologist. And even though the relationship didn't work out, I still credit him. He gave me a lot of information, a lot of knowledge. And I think the issue with multidisciplinary care in IR is this, okay? It's not the actual multidisciplinary aspect of it. I think it's that IRs need to elevate their game to be at the same level as the other specialties when it comes to comprehensive clinical care. And I think if we can operate on the same level playing field, then I think there are opportunities for collaboration. And I think there's good people out there who'd be willing to do it, right? But I think if we're not going to accept that responsibility, and if we're just going to be there to just kind of crush some sweet multi-level PAD cases and that's it, then it's not going to be a great experience. My 2 cents.
Good point.
Maybe we can. The original question I think was about training pathway and locums and how they intersect. And Kavi obviously talked a lot about the OBL space.
Yes.
I know I spoke in episode 1 about coming out of training and going directly into locums interventional radiology, which I probably didn't realize was that crazy of a thing until Kavi was like, "Oh wow, that's," and that was the first time that I realized, yeah, that was kind of crazy to do that. Maybe we can even talk about the kinds of phone calls that we have fielded.
Yes.
Definitely.
I have fielded phone calls from people that are still in training, people that are out of training, just out of training. I fielded, I think, 1 phone call from someone that is out of training but wants to go back for some additional advanced interventional training. Even got a phone call from the attending in my residency program who taught me a lot of what I know, which was very humbling, and I have to credit the podcast for that. It just made me feel like I've done something unique here. So I think that you may see a lot of people coming out of training thinking about doing locums interventional radiology as they try to figure out where the market's going to go. It does come with some downsides. And you might talk more about the OBL space, because I think that's a very different beast, especially because most interventional radiology training is still hospital-based, so it's not quite as big of a leap. But it is tough to come out and maybe use a product you've never used before, handle a condition you've never handled before, not have any backup, and be working in an environment where you haven't developed a reputation. And I defend a lot of locums doctors who may just come and maybe they work just 1 week a year, or 2 weeks a year, maybe only have been to the site once or twice. It's a very different risk profile when you're doing a high-risk procedure and no one knows your reputation. It's very easy to ruin your reputation.
Yeah.
Versus say you're coming to the site, like where you're going, or even some of my clients where I've been there steadily over many years,
Right.
I can afford to take some greater risks. So it's not easy, but the advantages are definitely there. Financial for sure. And we're going to talk about that at some point, but also seeing a broad variety of cases, not everything, and I have to be upfront about that, but also learning how to develop new relationships. It would pay dividends if you end up taking a permanent job afterwards.
Yeah.